Hey guys, welcome to PT Snacks Podcast. This is Casey, your host. And if you're tuning in for the very first time, first of all, welcome. But what you need to know is that this podcast is meant for physical therapists and physical therapist students who are looking to grow your fundamentals in bite-sized segments of time. So today, we're actually going to be covering shoulder pain that's not musculoskeletal pain. And I think that this is something that's so important to keep in the forefront of your brain, especially if you are wanting to be intentional, and I hope everybody feels this way, but intentional about screening patients and making sure that they're actually appropriate for your clinic. So the sooner that we are able to make sure that we are keeping these things in mind and capturing these patients, the sooner we can send them to the correct profession and get them the help that they actually need. So we're going to be covering some of the most common sources of shoulder pain that are not from the shoulder. And I would challenge you to pause this episode and just try and come up with that on your own. What all could refer potentially to the shoulder? Are we being all inclusive in this episode? Not necessarily. It's just a kind of a quick overview of some things to think about, but challenge yourself there. And then that way it's like our own built-in quiz. So before we do that though, if you've listened to the show at least 3 times and you feel like it's been really helpful, if you wouldn't mind pausing wherever you're listening to this and leaving a really brief review, whether it's on YouTube or Apple Podcasts, things like that, that would really mean the world to me. And if you're not following or subscribed, do so that you don't miss out on anything. I have some exciting things in the works that I'm experimenting with. So I hope that you stay in touch and that it's helpful to you. Again, yes, we should be good at what we treat, but we should also be good at recognizing what we shouldn't treat. So when we are talking about patterns that are related to musculoskeletal shoulder pain, our patients should probably have some sort of pain that's clearly linked to shoulder motion or loading. Maybe we can reproduce it with palpation or special tests. Maybe it improves with rest, or there's positional change, or we see a difference through PT as they're being treated to where we're making a difference, whether it's better or worse, we're impacting something. And even if it's not in the shoulder, hopefully we've been able to figure out if it is musculoskeletal, it's coming from something else like the neck, right? So identifying non-musculoskeletal pain, they might have constant, poorly localized pain. It might feel like deep or pressure-like, and it's not really altered by any shoulder movement or palpation, or you can't bring it on in an exam, even though you're trying to. It could be associated with systemic or autonomic symptoms. Maybe they have fever, this diaphoresis, which is basically like a lot of sweating without really having a reason to sweat. Dyspnea, GI upset, maybe they have unexplained weight loss, or looking at their medical history. Do they have a history of cancer, cardiovascular disease? Do they smoke? Do they have significant comorbidities that might be putting them at a higher risk for developing other conditions that are not really physical therapy conditions? So, and as I mentioned, failure to respond or worsening symptoms despite you feeling pretty confident that you're giving them the appropriate musculoskeletal treatment is a sign that maybe they need more workup. They need more future steps with a different provider. So some examples of other potential sources. This is where hopefully you've quizzed yourself, but it could be from pulmonary or the thoracic region. Maybe they have pneumonia, lung cancer, maybe a Pancoast tumor. If you're studying for your OCS, probably should know about that. Pleural effusion, pulmonary embolus. These are things where flags that should capture your attention. Could be cough, dyspnea, fever, weight loss, hemoptysis, pleurotic pain, smoking history, apical chest findings. So you can ask them if they have any history of a cough, shortness of breath, fever, night sweats, unintentional weight loss, change in sputum, and smoking history. So things that you could look at as a PT would be they're checking their temperature, their respiratory rate, auscultation or percussion of the upper lobes, things like that. Other things that could refer there could be cardiovascular. So Hopefully they don't have some sort of acute coronary syndrome or AMI, angina, or aortic pathology. So they could have like jaw, chest, epigastric discomfort, exertional or pressure-like pain, diaphoresis, nausea, autonomic signs, and you're looking for cardiovascular or other risk factors like that. So then you can ask, does pain change with exertion versus rest? Any chest pressure, jaw, neck pain, sweating, nausea, or breathlessness? And any cardiac history, hypertension, diabetes, hyperlipidemia, or smoking. Hopefully they've already filled that out on their medical paperwork. And then you can look at their blood pressure, their heart rate, rhythm, observe for any distress or diaphoresis. Another one, gastrointestinal or hepatic pain. So conditions could include cholestasis, say that 5 times fast, gallstones, pancreatitis, peptic disease, hepatic tumors. And things that could be associated with this would be right or upper left quadrant or epigastric pain, nausea, vomiting, jaundice, dark urine, pale stools, weight loss, or postprandial worsening. And you can ask them, do you have any upper abdominal pain, indigestion, change in appetite, nausea, jaundice, or recent weight loss? And then malignancy or systemic disease. Some conditions could be primary or metastatic cancer like lung, liver, bone, some sort of infection or autoimmune disease. Polymyalgia rheumatica are just a few examples. But you're asking, do you have a history of cancer, unexplained weight loss, night pain unrelieved with rest, systemic illness? And if their age is over the age of 50, that is going to put them in a higher risk, as well as failure to improve or rapid worsening despite appropriate musculoskeletal care. So you're asking any history of cancer, recent fever, chills, profound fatigue, or weight loss, and is the pain constant, including at night, regardless of what position that you're in? If you're seeing this patient for the first time, you might have already been able to talk through some of these things, but some quick triage questions that you could integrate into your normal exam or just checking up on them. You can ask them, is there anything about your health that you haven't mentioned? Fevers, night sweats, changes in breathing, digestion, or weight? And you can say it in a casual way where they're not freaked out, but you still get the information that you want. Another question is, does anything about this pain worry you because it feels different than other aches that you've had? Or does shoulder or neck movement clearly make this better or worse, or does it seem pretty unrelated to movement? In addition, you can always ask about constitutional signs. So those are like fever, chills, night sweats, fatigue, unexplained weight loss. You can, in your physical exam, incorporate like a red flag sweep that you just do with everybody, where you're checking their blood pressure, heart rate, temperature, respiratory rate, things like that. Just observing, do they seem distressed? Do they have diaphoresis, excessive sweating? What's their pallor like? What's their skin complexion like? Do they have jaundice, any clubbing on their fingers? That sort of thing. And we learned in PT school like a quick chest and abdomen screen where you can palpate, you can do focused auscultation, see if there's any pleurotic or visceral pain provocation that you're doing. And then shoulder. If a full mechanical exam is normal and symptoms remain high, suspicion for a non-musculoskeletal issue should be a little bit higher. So when do we refer urgently or emergently? So if we're suspecting some sort of AMI or aortic pathology, they have new chest pressure, exertional symptoms, autonomic signs, that would fit in that bucket, as well as any red flag pulmonary signs in a high-risk patient. So someone who is a smoker with progressive shoulder pain, cough, neurologic symptoms, you're suspicious of maybe a Pancoast tumor, that is also someone you need to send on very quickly. If they are displaying any sort of progressive, rapid neurologic deficit, systemic sepsis signs, or suspected malignancy with severe night rest pain, you also need to refer that. So in essence, if it doesn't make sense, dig deeper and make sure that you're maintaining these skills to make sure the patient that is in front of you is someone who should be in front of you. And if they shouldn't be, that you get them in front of the right provider that can care for their symptoms. Time is important. And I would argue that for everyone, if PT is not where they need to be, that is the best thing that we can do is to get them on to the next provider. So that's it for today, guys. If you have any questions at all, feel free to reach out at ptsnackspodcast@gmail.com. I will answer your questions to the best of my ability. If you want to get involved with our newsletter, I basically just send out a weekly letter summarizing our episodes like this or just other things that are going on. I try not to spam too much. Hopefully no one who is currently on the email list feels that way, but make sure that you actually confirm your email or you're going to get no emails. And then lastly, MedBridge is actually offering listeners over $100 off their subscriptions, which is really great as that's for a whole year. So if you just use the promo code PT Snacks Podcast, you'll get access to thousands of CEU courses or specialty exam prep. And depending on what level of membership that you want to go with, there's even an HEB builder if you're in the need for something that you can send on to your patients with their exercises. But other than that, I hope you guys have a great rest of your day, and until next time.